The hospital environment is home to a variety of pathogens given the volume of sick patients and the nature of a hospital's daily operational activities. Suboptimal cleaning of hospital surfaces can result in patients acquiring new infections associated with the delivery of healthcare, also known as healthcare-associated infections or HAIs. In Ontario, the three most common pathogens that result in HAIs are C. difficile, MRSA, and VRE, with C. difficile being the most common. Patients, healthcare workers, or visitors can unknowingly spread these pathogens throughout the hospital, which places everyone at risk if they come into direct contact with a contaminated surface. Additionally, all three pathogens have the ability to live on surfaces from weeks to months, which present a significant risk if missed during standard cleaning practices. HAIs represent a significant threat to the Canadian healthcare system. It is estimated that more than 200,000 patients are affected by HAIs every year, which is equal to about 1 out of every 10 patients admitted to the hospital. Additionally, 8,500 to 12,000 patients lose their lives each year due to HAIs, making them the fourth leading cause of death in Canada. Finally, HAIs represent a significant cost to the Canadian healthcare system, which estimates over $1 billion annually to treat these individuals. These costs are associated with increased supplies, laboratory processing, cleaning and laundry, treatment, medication suspense, and nursing and physician care. Current strategies for mitigating the spread of HAIs include the wearing of personal protective equipment, proper hand hygiene, and manual cleaning of hospital surfaces. Manual cleaning is accomplished using hospital-grade germicidal disinfectants which attempt to eliminate the microorganisms that are present on hospital surfaces. However, despite these best practices, a high incidence of HAIs persist. Thus, there is a need for additional disinfection strategies that can supplement current manual cleaning practices. One type of adjunct to manual cleaning practices are portable automated UV disinfection technologies which have been developed to combat the threat of HAIs. They function by emitting an artificially generated form of UVC light which replicates the electromagnetic radiation that is naturally produced by the sun. UVC has a wavelength that ranges between 100 to 280 nanometers, which is strong enough to destroy the genetic material of bacteria, viruses, and other microorganisms. By damaging the microorganism's DNA and preventing them from reproducing, UVC light-emitting devices are hypothesized to be an effective germicidal agent, especially against pathogens that have shown resistance to antibiotics. There are two main types of portable UV devices for surface disinfections that have been approved for sale in Canada. These devices differ in the way they administer the UVC light. One type of device emits a continuous stream of UVC light through a mercury bulb, while the other type of device, known as pulse xenon UV devices, makes use of xenon lamps to produce millisecond flashes of full germicidal light. These two devices also differ in the intensity of UVC light that they emit. The mercury bulb devices emit a continuous stream of UVC light at approximately 254 nanometers, whereas the pulse xenon UV device emits a range of light between 200 to 320 nanometers, making use of both UVB and UVC light. These devices require one person for operation, however, they differ in time required for administration. Mercury devices generate a single which can range from 8 to 55 minutes, while pulse xenon UV cycle ranges from 5 to 15 minutes. However, when operating these devices, there are a few things to consider. First, rooms must be vacant as exposure to UV light can be damaging to skin, eyes, or any other organic material that is present. Secondly, UV disinfection should only occur after manual cleaning since it is not capable of removing dirt or aggregated organic material by itself. Third, the device must be strategically placed within the room so that the UV light can reach every surface, including shaded ones. This may require the device to be run in multiple locations throughout the room. Finally, the device needs adequate time to disinfect the room. Time for disinfection varies depending on the device used, size and layout of the room, and the pathogens present. In order to determine which device would be the best solution for preventing and reducing the incident rate of HAIs, we conducted a literature review to examine the effectiveness of each type of device against the three most common pathogens in comparison to standalone manual cleaning practices in hospitals. We began by sifting through the literature to review the efficacy of portable UV light disinfection devices from the inception of UV technology up until 2020. Pulse seen on UV light disinfection devices demonstrated promising results in the reduction of C. difficile infection rates, with 4 out of 6 studies producing statistically significant reductions. When examining effectiveness against VRE, 3 studies were able to produce statistically significant results with an 18 to 50% relative reduction in infection rates, while 4 studies found very minor to no change at all. Similarly to VRE, the results for MRSA were mixed. One study produced statistically significant results with a relative reduction rate of 27%, while 2 studies showed the opposite, with results in favor to manual cleaning over pulse seen on UV light supplementation. These findings suggest that pulse seen on UV light is likely to be effective against C. difficile, but not so much against VRE and MRSA. Looking at the mercury bulb devices, 1 of 3 studies reported a statistically significant reduction in C. difficile infection rates, while the remaining 2 also demonstrated a reduction. However, the results were not found to be statistically significant. With respect to MRSA and VRE, 1 study published in 2018 demonstrated statistically significant results with a 30.8% reduction in MRSA and a 34.2% reduction in VRE infection rates, while an additional 2 studies for each pathogen did not produce any significant reductions. These widespread results make it difficult to draw any conclusions on the effectiveness of these devices. Although many of the studies demonstrated some sort of reduction in HAIs, the current body of research on UV disinfection technologies leaves much to be desired. Many of the study methodologies consisted of uncontrolled before and after study designs, thus resulting in a low quality of evidence. Additionally, manual cleaning practices varied among the different hospitals and rooms where the devices were evaluated. Furthermore, the type of device, length of administration, and protocols used for combining UV disinfection with manual cleaning practices also varied. By virtue of the variability between these studies, results were not conclusive or generalizable to any one hospital setting. Finally, some studies demonstrated conflicts of interest as authors either directly funded the research or were employees of the device manufacturer. Unfortunately, due to the current quality and inconsistency of the current literature surrounding these UV disinfection technologies, we are unable to determine their efficacy in the reduction of HAIs in the hospital setting. This limits our ability to suggest any one of these technologies for implementation, as the research was unable to produce any generalizable results in the reduction rates of HAIs amongst patients. This is further compounded by the fact that these technologies take considerable financial and human resources to implement, thus making certainty even more important for hospital administrators and decision makers. Therefore, we recommend that implementation of UV disinfection technologies remain under consideration until further research is conducted to determine the true effectiveness in the prevention and reduction of HAIs in the hospital setting. Fortunately, we might not have to wait long. State-of-the-art facilities such as the Mayo Clinic with Scenics Light Strike, Duke University with TrueD, and Canada's own McGill University with UVD robots have adopted these technologies and are currently evaluating their effectiveness. Therefore, we expect to see more research regarding these technologies as well as best practices for implementation soon.